Hello, this is Dr. Patrick Hu from Moffitt Cancer Center. We're really privileged to have Dr. Bijal Shah from our Malignant Hematology Department here today to talk about acute lymphoblastic leukemia. Thanks, Dr. Shah, for joining us.
Oh, thanks for having me. It's an honor.
Tell us about acute lymphoblastic leukemia. What is it?
Acute lymphoblastic leukemia is a cancer of those most immature white blood cell precursors. These guys were destined to become our B cells and our T cells, these sophisticated soldiers of our immune system that are used to help us fight infection, fight even in some cases cancer. I feel compelled to make an analogy. You know, it's as though, and I want you to imagine for a moment you're part of a rock band. I know this is a stretch, but imagine you're part of a rock band called the Remissions, and one of your bandmates just decided they were going to go completely off cue and do whatever they want. If you have someone on the keyboards, for example, who's just playing completely out of sync with the band, it has the potential to get in the way of all the other guys. And I would say that's exactly what we're talking about in the context of lymphoblastic leukemia.
That's a great description of cancer in general, Dr. Shah.
I couldn't resist.
Yeah, so it sounds like new treatments are sorely needed for ALL, especially in adults. And congratulations to you, because you're instrumental in this new FDA approval of TECARTUS, a cell therapy for ALL. So why don't you tell us about this new therapy, TECARTUS?
Sure. TECARTUS is a CAR T cell therapy. So what we're fundamentally doing is taking a patient's own T cells and genetically modifying them so they can now recognize the leukemia. We do something to a T cell that is unusual. We put an antibody and build it into that T cell and allow that antibody to talk to the T cells so it can now see the cancer and kill the cancer. And I'm excited to be able to report that we succeeded. And we were able to move this into the phase 2 setting where we could turn this into something that was really remarkable for our patients, a 71% CR and CRI rate. The majority of these were true CRs. So when we talk about CRI, we're talking about complete remissions without full count recovery. But over half the patients had true complete remissions.
Tell us about the team of people you have at Moffitt Cancer Center, and whether it's important to understand and go to a place with a lot of experience in giving this kind of therapy.
I'm so glad you said that. I couldn't do it without the team here. You know, we have a dedicated group of nurses, nurse practitioners, physician assistants, even physicians, all of who participate in the delivery of CAR T-cell immunotherapy. We meet weekly, sometimes even more often than that, to discuss the care of these patients, to make sure that we're optimizing what we can optimize, both before the CAR T and after the CAR T, so that we can carry them safely. I could name 100 people and I still wouldn't name them all. It's such an amazing group that we have here. And it's, again, such a critical piece to why we landed where we did.
What's the future hold now for this very exciting T-cell therapy?
We're looking at other ways of making CAR T cells. We have a partnership with Precision Biosciences, where we're doing a trial using an allogeneic CAR T cell product. Again, asking the question now, can we pull the cells out of the fridge so we're ready to give them whenever a patient needs them, and use that as a tool to help us land where we need to? We're talking about using new tools for making CAR T, increasing our efficiency, increasing our success, and we increase that remission rate, that cure rate that we all desperately want.
Do you think we're going to get to the point where we can even give them as an outpatient?
I think we'll get there. For me, the first step in reaching that goal is going to be understanding why we see the toxicity we do. And that seems to be a large reflection of what is the tumor burden going into the CAR T-cell immunotherapy and how much inflammation is there at baseline. And we've seen across a variety of diseases that sometimes cancer is by itself inflammatory. And when you have cancers that are by themselves inflammatory and you go in and you, again, in trying to treat it, you further increase or add to that, that can create a scenario where folks may experience more toxicity. So I think also coming in with lower disease burden will also help to do that. The less amount of leukemia or lymphoma that's present, the less inflammation is present, and the less toxicity we can anticipate. And this has been seen in other studies as well.
Well, congratulations on this FDA approval. You were really very responsible for it, and really led these studies and did such a wonderful job. And they'll now go on to help so many people with ALL. So we have Dr. Bijal Shah, clinical research star from our malignant hematology department. Thanks so much for being here today.
Thank you so much.